Okay. All right, good morning, everyone. We'll go ahead and start off our section about complement-mediated TMA or atypical HUS by a talk regarding atypical HUS in pregnancy. My name is Meera Sridharan. I'm one of the classical hematologists at Mayo Clinic in Rochester, Minnesota. I just have this financial disclosure. So kind of just an overview. So instead of focusing solely on pregnancy, what I actually chose to do is first start out by doing a very broad overview of complement-mediated TMA and how we make a diagnosis even outside of pregnancy. I chose to do this because I think maybe we all have different understandings of how we do this and maybe how we go about treating it. Then I'm going to circle back and talk specifically about pregnancy and how we think about this disorder in the setting of pregnancy. So these are the objectives that I hope that you'll get out of this talk today. So starting from the basics, why we're all here today, thrombotic microangiopathy. So what is it? It's a clinical pathologic syndrome characterized by thrombocytopenia, microangiopathic hemolytic anemia, and end organ damage. So what is that? So if you look at that cartoon on the right side is a healthy blood vessel. You have red cells getting to, if you imagine at the very end of the blood vessel, there's an organ. So it's getting to the organ and appropriately it. That's what is supposed to happen. What happens in a thrombotic microangiopathy, in that endothelial surface of those blue cells there, you have some nidus that allows the body to form more blood clots than it should be forming. And so when the red cells go through, they reach this area of like vascular resistance. So that just means blockage. And when they try to go through, it's really hard for them to go through. So that organ that's there can't be appropriately oxygenated. So you end up with some tissue damage. And then also, because the red cells are going through this area that's really tight, they're sheared, meaning they're broken apart. And so you may hear your hematologist or nephrologist talk about, we're seeing things on a peripheral blood smear that looks like schistocytes. So that's kind of what those triangular shaped cells look like in the picture over there on the peripheral smear. So as a hematologist, I'm suspecting a thrombotic microangiopathy when someone has low platelets, when they have an anemia and there's signs of red blood cell breakage, and when I'm seeing signs of those schistocytes. I also think about a thrombotic microangiopathy if on a biopsy there's evidence of thrombotic microangiopathy. One of the more common organs that's biopsied is usually the kidney in this disease process. In terms of thrombotic microangiopathy, complement-mediated hemolytic uremic syndrome, or atypical HUS, is not the only diagnosis. There's a lot of different things that can cause it. There's a couple other sessions going on right now regarding TTP, or ADAMTS13 deficiency. Thrombotic microangiopathies can also occur because of other secondary disorders. So having autoimmune disorders, the state of pregnancy can cause it, undergoing transplant can cause it, getting treated with certain medications can cause it. But also dysregulation of the alternative pathway of complement can also cause it. So traditionally that term has been called atypical HUS. So that may be what you're familiar with hearing, but kind of over the years, we're shifting the way we call this disorder. So a lot of providers are calling it complement-mediated TMA. Some are calling it complement-mediated HUS. But what we're talking about is a thrombotic microangiopathy related to dysregulation of the complement pathway. So I'm not going to go through a lot of these details, but what is the complement pathway? So, it's a very complicated pathway that is involved in basically protecting your immune system, more or less. And there's 3 arms: the classical, lectin, and alternative pathway. When we're speaking about atypical HUS or complement-mediated TMA, we're specifically kind of talking about dysregulation of this pathway, the alternative pathway. So the alternative pathway, it's unique in that it's kind of always on in the background, and it can kind of ramp up or ramp down when your body needs it to. And the body's able to do that because it has different regulatory proteins that allows for that. And so what happens with atypical HUS is there's some dysregulation in that ramp up, ramp down process. And then so that leads to more membrane attack complex that's at the red kind of left part of the screen. And so this causes kind of that endothelial inflammation and microthrombi formation. To more pictographically put it, so if you look at this cartoon here, you have the complement pathway. And so those blue deposition things, those are basically the membrane attack complex attaching to the endothelial surface. You're getting more clot formation. Then it makes it harder for red cells to get through, oxygenate, and the red cells are getting sheared. So if you imagine that going on through your tiny blood vessels, that's essentially what causes the damage. So I put this up here not so you remember all of it, but it just to help you understand some of the testing that your doctors may order. So with dysregulation of the alternative pathway, it occurs due to dysfunction and loss of function proteins or gain of function proteins. And so in the lab, when we're trying to make a diagnosis, sometimes we will assess for these things. And so that's the rationale for doing that. But how do we make a diagnosis? So I'm doing this with a case. The patient is not pregnant. You see she's like 64, but we'll get back to pregnancy in a little bit. So a 64-year-old female, she has no significant past medical history. She presents to the hospital with confusion, abdominal pain, nausea, and vomiting. And so when she presents, she has a low hemoglobin, she has low platelets, and she has signs of kidney damage. And we assess that by that creatinine number. So that number is really high, so it's kidney damage. So then I say, okay, why is she anemic? Why is her hemoglobin low? So I order a lot of labs, and all the labs show there's evidence of red blood cell breakdown. That's what the elevated LDH is. That's what that low haptoglobin is. That's what that elevated bilirubin is. So then I say, okay, what are some causes for why the red cells are breaking, and why are the platelets low? And so I look at the cells under the microscope, and I see those schistocytes. So there's like little triangular type cells that shows that the red cells are being fragmented when they go through the blood vessel. So putting it all together, I say, okay, this is very suspicious for a thrombotic microangiopathy. But there's a lot of different types of thrombotic microangiopathy, right? So I can't just say, okay, it's, yay or nay. I just kind of have to think about which one it is. So what we first do as clinicians is we first try to rule out TTP, because we can do that by getting an ADAMTS13 test, and there's a very specific treatment we need to use for TTP. But if I exclude TTP, then I go through the other processes of what could cause a thrombotic microangiopathy. And so essentially for complement-mediated TMA or atypical HUS, it's what we consider to be a diagnosis of exclusion, meaning I don't really have another reason for it. And we also can try to use laboratory tests to help support our diagnosis. But ultimately, it's what we consider to be a clinical diagnosis. And I think that's one of the most maybe frustrating things for patients and providers as well, is there's not really a 100% lab test where I can say, let's get this, and this is the diagnosis. But lab testing can be helpful. I'm going to walk you through that. And I think there's going to be some other talks later today that will also kind of show the benefits of lab testing. So kind of what lab testing could we get? So complement serology. So I kind of showed you a little earlier about the dysregulation that can occur with the complement pathway. So we can look at like the different protein levels, different activity levels in the blood. The issue with doing that is that the testing for it's not great. Studies have shown that if you just get like one test alone, it's not very sensitive. So what we've moved to doing is trying to get like cascades or panels of tests, where if we get those, then we think the testing can be sensitive, meaning a pretty good chance of picking up some abnormality, but it's not very specific, meaning some other things could cause that abnormality that's not related to atypical HUS. You'll hear about today a kind of a newer method of assessing complement with a cell-based assay called the modified Ham test, and so I'll wait for that conversation for later. Some types of complement-mediated HUS can be caused by antibodies, so we can assess for antibodies in the blood. But again, without these tests, you can still try to make a clinical diagnosis because sometimes these tests will not confirm your clinical suspicion. We also can get complement genetics. And so with complement-mediated HUS or atypical HUS, a good proportion of patients do have complement protein genetics. But the issue is that a good proportion also do not have complement pathogenic mutations. And so because of that, a lack of a genetic mutation does not rule out atypical HUS. We can't use it as a diagnostic test per se, but we can use it kind of as a supportive test. And I'll show you later how else we're using these complement genetics when we manage the disease process. So kind of taking it back to the case just to show you how kind of I use the complement serology. So I work at Mayo, so we have this panel where we get kind of 9 analytes. And so I look at them all as a whole. And so that SMAC, when it's high, that's supportive of complement activation. When that factor H is low, it suggests more alternative pathway. And that when that BB is elevated, it's also more suggestive of alternative pathway. So that supported our clinical suspicion. And then the complement genetics, the patient ended up having a variant in this gene called CFH, but it wasn't like necessarily we consider to be a pathogenic variant, meaning we don't have enough evidence saying it's causative of the disease process, but at least she had some type of variant there. So your clinician, what they probably do when they're considering the diagnosis is they take everything together and they say, what do I think is the cause of the patient's TMA? So clinically, if someone doesn't have TTP and you've excluded other causes, you could be suspicious for complement-mediated TMA. And then you can use laboratory-based assessments, so complement serology and complement genetics to help support that diagnosis. I will say, if you had a high clinical suspicion for complement-mediated HUS or TMA, and you didn't have the confirmatory genetics or didn't have the serology, you could still make the diagnosis based off of it being a diagnosis of exclusion. So that's kind of important to remember because sometimes you don't have all those things matching up. Hopefully there will be a day and time when we have a diagnostic assay that we can 100% say it completely matches up, but I don't think we're quite yet there. Okay, so how do we treat this disorder? And so I'm talking about treatment for all complement-mediated TMA, not necessarily just pregnancy associated. So complement inhibition is the definitive treatment, okay? But before we knew a lot about complement-mediated TMA, a lot of patients got plasma exchange first line and still get plasma exchange first line because, as you can see, the diagnosis is not very easy. And so the treatment of choice for TTP, which is at low atom TS13, is actually plasma exchange with other medications. And so a lot of patients do get started on plasma exchange, and many of you may have been. We do have data to say that some patients will have some response to plasma exchange, but the response is not persistent for a lot of patients. And a lot of times the plasma exchange will not improve the kidney function, which with patients with complement-mediated TMA, the kidney function can actually be one of the significant organs that is affected. There are some types of complement-mediated TMA that are antibody-mediated, like factor H antibody-mediated, that are very plasma exchange responsive, okay? But kind of our definitive treatment is complement inhibition. You guys are probably familiar with these names. So in 2011, eculizumab was approved. It's a C5 inhibitor. And studies have shown that it inhibits progression of TMA. It helps prevent recurrence. And then in 2019, the longer-acting kind of counterpart, ravulizumab, was approved. It had very similar efficacy findings, which is kind of showed by this comparative study that was done. There's not a head-to-head comparison study, so it's really comparing data for each individual clinical trial. So is one better than the other in terms of efficacy? Not necessarily. There is a big difference in how it is dosed, though, which makes a difference for patients. So eculizumab, when given when its maintenance phase, is given every 2 weeks, and ravulizumab in its maintenance phase is given every 8 weeks. So obviously, for someone coming in for visits, those type of things, you would think that maybe one would be preferred over the other, maybe the 8-week one over the 2-week one. Someone from our group actually did investigate this question by sending out surveys to you guys, and you guys did indicate that there was an overall preference for ravulizumab over eculizumab. The infusion frequency was one of the main factors. Because there were less infusions, it didn't really affect daily life as much. So with complement inhibitors, there are risks. So the major one is infection. So kind of the warning when we prescribe these medications, we need to make sure everyone is appropriately vaccinated, definitely for the meningococcal vaccination. On this slide here are just some of the cases of infection that were reported with the initial trials. If you need to start the complement inhibitor therapy like more urgently, we do start prophylaxis with antibiotics. And actually the CDC recommends now that we continue that antibiotic prophylaxis throughout the duration of their complement inhibitor therapy, despite getting the vaccination. So that's one thing that I think has evolved kind of over the last several years because of showing some breakthrough infections. So I put this up here just so you remember, not to memorize everything, but if you're getting vaccinated, just to make sure you ask your doctor about two different vaccines. Okay, so this slide here is really meant to say thrombotic microangiopathy. It's not just a disorder that affects the blood or maybe affects the kidneys. It's a disorder that has the potential to affect every organ, okay? And so because of that, it's essential that when a diagnosis is being considered, and even in follow-up, that a patient is being cared for in a center that's able to do multidisciplinary care. There's been studies that have shown that if you are getting kind of care at a multidisciplinary care center, that you can lead to earlier recognition and better outcomes. And so for patients that already have a diagnosis, I do recommend that there's at least, it may not be like you have to go there every month, but you at least have like an opinion just to make sure all of your organs are appropriately accounted for. And so that multidisciplinary care would include specialists and like hematologists, nephrologists, OBGYN, transfusion medicine, pharmacy. Okay, so now duration of complement inhibitor therapy. So this is I think this is maybe more of a controversial topic. It'll be interesting to hear everyone's experience after this talk. There's not really a consensus. I put up to 3 general approaches. One is to continue indefinitely. Some people consider tapering the inhibitor, and then some consider discontinuing. I'm going to talk a little bit more about the discontinuing approach because I think in a lot of the larger centers that has been utilized more recently. And whenever you're discontinuing a complement inhibitor, you have to take into account, okay, what's a patient's risk of relapse? So there's a lot of different things that could affect relapse, but complement genetics are one of the things that has been thought to be the most helpful to look for deciding who's at a high risk for relapse versus who's at a low risk for relapse. There's other things that we take into account as well, such as age of presentation of the initial episode. We also take into account whether someone has already had a kidney transplant or not, because that also goes into that decision-making process. And then also, so I'm a hematologist. I work closely with my nephrology colleagues, so my kidney doctors. And if they tell me, like, if we stop this therapy and someone has a relapse, their kidneys will never recover, then I may be less likely to say, let's consider complement discontinuation. So we were really looking at where the patient's kidney function is right when we're going to consider discontinuation. So every institution may have a different protocol for this. At Mayo, what we've been doing is all patients that respond to complement inhibitor therapy, we continue them on it for at least 6 months. And then at 6 months, we assess, like, have they been in hematologic and renal remission for at least 3 months? If they have, and things have stabilized, then we have these discussions. We look at their complement genetics and we say, okay, did you have a variant that we could say was a causative variant? Did you not? If you didn't have a variant, then we say, okay, let's talk to the rest of my multidisciplinary team. Do we all agree that it would be safe? And if the consensus is that we think it would be safe, then we talk with you, the patient, and we talk about potentially discontinuing. The thing is, whenever we discontinue, it's not like we say, okay, bye-bye, I'm never going to see you again. You're going to still be part of our practice. And a lot of times I'm still doing a lot of lab work, and we do some type of clinical follow-up, whether it be with hematology, nephrology, or your primary care, to make sure that if there is a sign of relapse, we see it and we restart the complement inhibitor therapy. We do this very closely for a year, and then we kind of extend the duration a little less frequently thereafter. But we still kind of keep a pulse on kind of how you're doing if you're willing to follow up with us. Yeah.
So I understand that like 700 or 800 patients with this condition in America. And how many of those patients does that Mayo Clinic interact with either in person or through dialogue with your doctor?
Yeah, that's a good question. So, I mean, we're a referral center, and so the number varies over the years. And so, like over between hematology and nephrology, in terms of like first time like presentation at Mayo, it's probably like 3 to 4 patients a year, first time presentation. But we do have patients that will come in for like a second, third opinion, and so then that number does go up. I don't have the the numbers for that, but it's approximating like into the 10s or 20s. But then, kind of all of our members are also part of groups like this, where we learn from others' experience and try to get an understanding. In addition to that, because we have our own kind of reference lab, we do get like experience looking at those results, and sometimes outside clinicians will call us and give us like clinical updates on a patient or clinical questions to us. And so in that process as well, we're not like directly caring for the patient, but we're at least learning how the patient is doing with kind of our diagnostic strategy and potentially our treatment strategy. Does that answer your question?
Yeah, because I mean, we're just 10 months into this with our teenage daughter, so I think, okay, we seem to be exceptional doctors who are caring for her in Charlotte, but that process, is there a cheat sheet for parents of how to push or suggest to the provider, hey, get in touch with
Yeah, so I think I think it's a conversation with your local provider. So a lot of providers who see this diagnosis like for the first time, they wouldn't feel badly if you were to be like, okay, do you mind if we reach out to someone at a center where they maybe more regularly deal with this to get questions answered? I think a lot of providers do that actually quite regularly. So I think as someone that has like a loved one who has this disease process, I think you can ask those questions and just say, oh, I was at this meeting. Are we able just to have someone else look at the case to make sure that everything is aligning with what other centers would do?
I mean, I think just from the process of just seeing this right now, I would not just ask, hey, is it okay?
Yeah.
Let's get this.
Yeah, 100%. So I'm being more cautious just because I don't know what you have available for other providers by you. So I don't want to get rid of that relationship that you may have with that provider if that's the only provider that you have in your area.
It's going to be extraordinarily good doctor.
Yeah.
The fact of the matter is that, I mean, for example, the doctor recently said in a conversation, we're 9 and 10 months into this, and he's been, well, her labs are really good, and I think we can, not right now, but maybe 3-4 months from now, we can start to think about transitioning her off. And the minute I heard that, I said, I want to get somebody else.
Yeah, and I think that's completely valid. And I think it's also helpful just because then your local provider could maybe see what other people are doing as well to see how to monitor if that decision is to go off of therapy. So I think it's very right to be cautious. So, yeah.
What's your protocol for using urinary dipsticks?
Yeah, we have it on there. I can't remember if it's on the end of the side. So we have our nephrologist actually will give us like recommendations based off of where the patient's renal status was at the time of discontinuation. And so if they still had like significant proteinuria, things like that, then we will do kind of more of a urinary assessment. Again, what I have on here is kind of what we came up with as a group a couple of years ago, but it's very individualized for patients. So some of our nephrology colleagues will still follow up the urine pretty regularly. We don't do the dipsticks as much. We do more of the urine analysis because the patients are coming for blood testing anyway, so we can do the full test. So. Yep. Yeah, and again, that comes down to because with our practice, because we're having patients come for lab testing as well, we don't necessarily need to just do the dip. We can do the full urine analysis. So that just comes down to like again, if you aren't close to a medical center, those type of things, then the urine dipstick is like a nice surrogate kind of thing. So. So in terms of the presentation spectrum, yeah, so some patients will present where the kidney dysfunction is maybe something that is picked up earlier than some of the hematologic parameters. And so that's why the nephrology kind of buy into this discontinuation protocol is necessary. Where some patients, I am able to see evidence of the hemolysis thrombocytopenia. I will say, since we started this discontinuation protocol, I've only had one patient have a relapse. And we've done it, I'm trying to think of my numbers off the top of my head, but we've done it in at least, like I would say, more than 20 patients now over the course of the years. Granted, some of these patients may have been lost to follow-up, but I can think of one relapse. And her relapse was really, we saw changes in her renal function that made us get worried. A lot of her hematologic parameters weren't dramatically different. There's a lot of things that can affect renal dysfunction. So the question at that time was, do we want to do another kidney biopsy, those type of things? But it wasn't thought to be necessary at that time. So we opted to just to restart the complement inhibitor. So, yeah. Yep.
Some centers, we are not able to do C5 activity or measuring severely for factor B or its C5 beta. Do you see a correlation on your seronegative testing and, for example, LDH or haptometer?
Yeah, good question. No, so yeah.
Sugar, like sugar.
Yeah. So with the follow-up testing, we have the complement serology in here. More so, and I think everyone probably here in the experts in this area would agree, because we don't have a really good understanding for what we will see in this follow-up setting. So it was more to gain an understanding of what we will see and will it correlate and how will we intervene. So we have not seen good correlation necessarily. The reason I put the C5 inhibitor on here, and this just comes from I think knowing things about when the inhibitor is out of the patient is helpful to guide how closely you need to monitor them. So we've seen in patients with eculizumab that when we stop it, the C5 inhibitor can be blocked, like the C5 activity can be blocked for like 9 months. So the eculizumab is just in the body for that long. It's not weight-based dosing, and so we've seen it last for a really long time. And so when providers are saying, okay, we're going to follow up for like a year of close follow-up, but that C5 inhibitor is still there for like 9 months, right? It kind of pushes that date forward. So that's why I recommend the C5 inhibitor. So that way, as a provider, you know, okay, I'm still being blocked, that the patient's still being inhibited. So now when the inhibition is gone, this is my time point for when I'm going to maybe more closely watch. So that's why we add that, because of that knowledge. I understand that a lot of places don't have that available, but that's just since we have it available, this is what we are doing.
The last question, do you have any correlation between C5 activity and CH50? Because the markers...
Yeah, very good. Yeah, good question. Yeah, so we do. Yeah, so realistically, if C5 is being blocked, the CH50, H50 could potentially be blocked. That's actually how we identified the long is we were getting these complement serology panels for after stopping it, and the H50 in a patient was really low, and I didn't have a great explanation, so we checked eculizumab levels, and that's why we knew it was still there. Yeah, so that's a good surrogate. And so for patients on ravulizumab, I'd actually prefer to do H50 over C5. So, okay. So this kind of summary for just complement-mediated TMA, diagnosis, one of exclusion, treatment, we talked about complement inhibitor therapy. So now let's talk about pregnancy. So when we think about thrombotic microangiopathies in pregnancy, you may kind of see the definitions of pregnancy-specific TMAs versus pregnancy-associated TMAs. So what does that mean? So pregnancy-specific means that this TMA you'll only see in pregnancy versus pregnancy-associated means these disorders you could see outside of pregnancy, but right now it's being associated with pregnancy, okay? So pregnancy-specific TMAs, so those are things like preeclampsia, HELP, pregnancy-associated, so that's TTP and complement-mediated TMA. So to differentiate between the two latter ones, it's really the ADAM-TS13. If the ADAM-TS13 is greater than 20% or normal, then it's not TTP, so then you're thinking more complement-mediated TMA. So this slide is just to represent, it's very difficult to discern between these things sometimes with just laboratory parameters. So when you're looking at like differences between TTP and CM-TMA, the renal function is usually worse with that compared to TTP. And then when you're looking at things like preeclampsia and HELP, one of the big differentiators is like the time of presentation. So if someone is presenting with symptoms of like thrombocytopenia, anemia, hypertension, and it's their first trimester, then it's not going to be preeclampsia. It's not going to be HELP because that shouldn't be occurring that early on. So as a provider, you're going to say, okay, is this one of the pregnancy-associated TMA? So it's something like TTP or complement-mediated TMA or HUS. So why are we so focused on complement in pregnancy? And it's because the complement system is very active in the normal pregnancy process. It helps with things like implantation. It helps with things like developing the placenta. It helps with cervical remodeling. So if you have someone that has innate dysfunction in the alternative pathway, that can affect all of those processes. It can lead to miscarriages. It can cause preeclampsia. It can lead to early births. So for pregnancy-specific TMA, so those are things like preeclampsia and HELP. So we have these definitions for them, but it's kind of a continuum. You can have something evolve into another thing. But the specific definition for preeclampsia is gestational hypertension accompanied by greater than one of the following new onset conditions, greater than 20 weeks gestation. So proteinuria, acute kidney injury, elevated liver function test, thrombocytopenia, eclampsia has a lot of the neurologic findings in addition to the preeclampsia. So then HELP is really characterized by the microangiopathic hemolytic anemia, liver enzyme abnormalities, and a low platelet count. The main thing to remember for this, so again, it shouldn't be happening in the first trimester. So if it's happening kind of in the second or third trimester, the way you manage it is you manage it symptomatically. So bringing that blood pressure down, watch the baby, and then deliver if there's progressive TMA. When like hematologists and nephrologists get involved is if despite delivering baby and despite the best measures, the renal function worsens and there's no improvement of the TMA, then we're saying, should we be thinking about something else? Should we be treating this as something else? So pregnancy-associated TMA, so again, this is either complement-mediated or TTP. We differentiate by the ADAM-TS13. So for complement-mediated TMA, so about 16% of all cases of atypical HUS occur in kind of women of childbearing age. Pregnancy-associated HUS and complement-mediated TMA have very similar presentations. It's really hard to differentiate between the two, so we really kind of treat them very similarly. And most of the time when it's occurring kind of in the postpartum period. So how do we manage pregnancy-associated TMA? So if you're thinking it's complement-mediated TMA, you can consider C5 inhibitor therapy. A lot of patients will be exposed to plasma because of that similar rationale I gave you in my earlier slides. So it does work in some cases. With the C5 inhibitor therapy, there's not really controlled trials. At the time of that publication in 2020, there's probably more now. There were greater than 35 cases of patients receiving eculizumab in pregnancy-associated CM-TMA, and the majority achieved hematologic and renal remission. So for patients that present postpartum, complement inhibitor therapy should be started. Eculizumab or ravulizumab could be utilized. When it's presenting antepartum, so when baby is still in gestation, that's where I think as a mom, it gets very, you worry, is it going to hurt my baby to get these complement inhibitor therapies? So, if delivery can happen, that's usually the option that is first made. But then if the patient doesn't get better, then that complement inhibitor therapy is considered. There is safety experience that exists with eculizumab, a little bit from CM-TMA, but mainly from data that we have from a different hematologic disease process called PNH. So this is a disease process that can also be treated with C5 inhibitors. And with PNH, we do have data on a decent amount of pregnancies showing that it is reasonably safe to use in pregnancy. It does cross the placenta, as you will see, because it was found in the cord blood samples. But when they looked at the inhibition of complement in the patients that had eculizumab, they didn't have enough levels to actually block complement. So although it crossed the placenta, it wasn't at adequate levels to cause C5 inhibition. There was a different study, really small granted, but it was in 2 newborns, and they checked concentrations in the newborn. And yes, there was eculizumab present, but it wasn't high enough to block complement. So what about breastfeeding? So is it safe? So we do have some data with PNH again, where they checked breast milk from moms that were on eculizumab, and they didn't find eculizumab in the samples that were tested. So based off of this data, when I'm counseling patients who we do need to consider complement inhibitor therapy, I kind of show them this data and I say, I think it's reasonably, safe to consider eculizumab, also to breastfeed, because I know that's very important for a lot of moms. So this is something that hopefully will put you at a little bit of ease. But you may be asking, well, what about ravulizumab? You just showed me all this data that that's maybe the preferred medication for some patients because of the every 8-week dosing. So we don't have the same data with ravulizumab that we have with eculizumab. So from the prospective clinical trial for ravulizumab with CM-TMA, there were 8 patients that were diagnosed postpartum, and they responded appropriately to the ravulizumab, but none of the patients reported breastfeeding. So we don't have antepartum data, we don't have breast milk data. And so we actually just had a conversation about this yesterday in one of our roundtable discussions about, what are providers recommending? And, I think some providers are saying, oh, it should be safe to use ravulizumab because it's similar to eculizumab. But ravulizumab is a smaller molecule, and so we can't make those generalizations. So I would say, if it was me, if it was, my sister, I would actually say use eculizumab, don't use ravulizumab. That would be my preference. 5 minutes, okay. So is it safe to be pregnant? We had a history of atypical HUS. So it's not contraindicated, but there are risks. So this kind of takes me back to important to be in a part of a multidisciplinary team. So you need to be at a center that is comfortable with managing patients who have a history of atypical HUS. The maternal risks are kind of preeclampsia, HELP, renal deterioration. Fetal risk is preterm risk and intrauterine death. There are certain things that we could do to kind of decrease risk. One is to maybe advocate that try not to get pregnant until you've been 12 months in a relapse-free remission, so just be far enough away from that incident event as possible. And then also to manage centers as a high-risk pregnancy, so basically to have close monitoring. Other things that we kind of do with the kind of multidisciplinary approach is, and this is part of if you're working with your maternal fetal medicine group, they may do more assessments, more blood pressure assessments, more ultrasounds, more blood counts, and that would typically be done with a pregnancy not associated with complement-mediated TMA. So what about risks for the kid developing atypical HUS? So remember that complement variants are only risk factors. It doesn't mean that they're going to develop atypical HUS because the penetrance is not 100%. So I won't spend a lot of time talking about this, but I think some patients like to see data when they're considering having children or not. And so this is probably the largest published cohort of pregnancy outcomes in patients with complement-mediated TMA. And I'm going to go to the summary slide just because it's hard to piece this out just from this picture here. But basically what they saw is that they saw infants born from a pregnancy complicated by CM-TMA had a lower gestational age. Patients were more likely to need ICU care. I think the big thing, though, is that they saw that pregnancies after an established CM-TMA diagnosis in the mother seemed to be more successful when compared with pregnancies before a diagnosis of pregnancy-induced CM-TMA. So that suggests that it's maybe the multidisciplinary care pre-counseling that helps support that pregnancy. But again, these are kind of speculations based off of the data that we're seeing. And then I'll end this presentation just by, I know the focus was supposed to be pregnancy, but we're all I'm a woman. Some of you are women who have CM-TMA, and I think it's sometimes hard to get lost in your disease process and forget about kind of just you as a whole and your whole healthcare screening. So although you have atypical HUS, complement-mediated TMA, don't forget about the other things. So you still need to get appropriate cancer screening. You still need to make sure you're up to date on your vaccinations. Still need to visit with your primary care physician for things like cholesterol, diabetes, and hypertension, because those are still real things. And so with that, I am open to any other questions.
Yeah. In the recent slide, there was one about a pregnant woman would reduce at 25%. But is that with her being on treatment or without treatment?
So that is, I can actually speak to with treatment or not treatment. So a lot of patients, because now we're doing this discontinuation protocol, so they may not actually be on treatment at the time of considering pregnancy. If you are one where the decision was made to continue eculizumab, then you would theoretically be on treatment. So the risk again, I don't have the data to say this, but would theoretically be lower. But in a patient who we had stopped eculizumab and they're considering pregnancy, I would not start prophylactic treatment. I would actually just observe and see how they do without complement inhibitor therapy. If we need to start it, then we have the data to say it's safe to start it, but I wouldn't do it prophylactically, if that answers your question.
Just watch really closely.
Correct. That's what would be my recommendation, because some patients do not relapse, and so you don't necessarily need it. And the thing is, what's hard about starting treatments is it's always difficult to know when to stop, right? So if I were to tell my patient to start it when you get pregnant, what would be the end to that? Would I just do 6 months after delivery? And there's not really data to support that either. So
just one more follow-up.
Yeah.
But the discontinuing medication, if you have one of the genetic factors like factor H deficiency, you wouldn't suggest discontinuation no matter what, right?
So I don't want to make a generalized statement, because when you look at so you're saying the complement genetics. So when you look at the complement genetic reports, it's very difficult to interpret sometimes. But if it says a complement pathogenic variant in CFH, my bias would be not to discontinue. I think everyone has needs an individualized look, though. So I don't want to make a blanket statement. But if someone has a pathogenic CFH variant, I'd be less likely to discontinue. Yeah. Okay. Any other questions?
It's not related to pregnancies, but because of job loss and insurance issues, I'm discontinuing Solaris. I've been doing it for 3 years. I'm ESRD on dialysis. What am I asking my hematologist to test while we can get insurance again and get back to Solaris? Am I asking to check my C5 levels? What am I asking them to monitor so that I'm dying?
Yeah, no, so can I ask, so thank you for sharing your story. So the recommendation from your provider, though, was to continue Solaris. It was just because of insurance.
It's just insurance right now.
Okay. Yeah. So, I think from the hematologic standpoint, your kidneys are obviously being monitored because of your dialysis. It would really be checking your blood count and your platelet, like hemoglobin and platelets. With end-stage renal disease, you may already have a lower hemoglobin. I don't know, but so they would have to kind of just see if there's a change in that. If they are seeing dramatic changes from your baseline, then they would have to check hemolysis parameters. So hemolysis, so things like LDH, haptoglobin. Yeah, but then so it'd really just be they're getting CBCs, I'm assuming, with your dialysis periodically. So it would be checking the hemoglobin and platelets, make sure they're stable. But if they see declines in either, then it needs to be evaluated more.
How frequently? You think once a week?
How often? No, you don't need it that frequently. How often are you getting them for dialysis?
Monday, Wednesday, Friday.
Okay, so and you're getting CBCs that frequently?
No, monthly.
I think monthly is adequate.
Okay.
Yeah.
Okay,
Yeah.
thank you.
Can we also suggest that she reach out to Alexion?
I did.
You did. All right, and then we have the patient assistance fund that would perhaps help cover the cost.
Yeah, certainly. So I think your medical provider, like they have all those resources that were just said. So if your medical provider thought it was best for you to continue on the complement inhibitor therapy, there are kind of support avenues that you could explore that hopefully we can help you with, or people here can help you with today. So yeah.
What do you do in patients with confirmed diagnosis of complement-mediated polyuria syndrome who do not respond to eculizumab? Do you increase the dose to 1,500? Do you switch to ravulizumab?
So that's a good question, and it's a complicated one. So my question would be, why aren't they responding? And the other question would be, do we have the diagnosis right? That would be my other question. So the first thing I check is I make sure that, and again, I'm able to do this because I have the labs available. I know a lot of people just don't, is I make sure that my levels of eculizumab, ravulizumab are therapeutic, and I'm appropriately blocking complement pathway. If I'm doing that, then I see no good reason to actually increase doses, because I have confirmation that what I'm trying to block is being blocked. So then I'm actually going down the strategy of, do I have the right diagnosis? If I'm not getting appropriate complement blockade, then I go through, there's certain, like a very rare variant, but it's mainly in the Japanese population that don't respond, but you can do testing for that as well. But if I am getting appropriate complement blockade, then my question is, what am I treating? Because it means that the complement inhibitor is not doing what I want it to do. So I would have to look at like the case specifically and see how they presented and go about it that way. So yeah. Do I have time for a question? Or okay, one more question. Okay, yeah.
There was a slide that talked a little bit about Solaris versus
Mhm.
Ultomiris. Ultomiris had like 3 deaths or something? Would you say it's less?
So, and I think maybe even other people in here may be able to answer this a little. The trials, so that population that did the Ultomiris, like, although there were 3 deaths, some of those patients like maybe were sicker than the atypical HUS population. Some of the patients there, if we go back and look at the data, may not have truly had atypical HUS, may have had other TMAs from other disorders. And so I think the consensus is that although there were those 3 deaths, we don't think there was actually a significant difference in efficacy. It was just a difference in the population that we were studying with that trial.
Do you have any data related to pregnancies with AHUS where there's been a kidney transplant in place? By any chance?
I'm trying to think of you can maybe find me after this and I can get your email and I can send you something. I don't have like something on the top of my head that I can think of a large study, but I have case reports. So yeah. Any other questions? Okay. Yeah. All right. So thank you so much for your conversations and let me know if you have any questions afterwards.